Hello everyone, this is Stephen and I worked with Alex. We'll be presenting on muscular dystrophy, but more specifically Duchenne's muscular dystrophy in the pediatric population. Duchenne's muscular dystrophy is quite common in this population and that's why we'll be focusing on that. And it obviously significantly alters the anesthetist anesthetic plan. So for our objectives, we'll be discussing the implications and working through the disorder by understanding the causes and what we could do as providers to recognize the signs and symptoms in patients that have not yet been diagnosed. We'll discuss the pathophysiology, how the disease will affect our anesthetic plan, and some of the controversies associated with developing an anesthetic plan for children with the disorder. At the end of the presentation, we will discuss a case report related to an undiagnosed case of Duchenne's muscular dystrophy in a pediatric patient undergoing surgery. So, what is muscular dystrophy? Um, it's a set of heterogeneous diseases that are listed in the slide, including Beck's muscular dystrophy, Duchenne's muscular dystrophy, limb girdle dystrophy, and these describe a set of diseases that affect muscle fibers, with the most common being Duchenne's muscular dystrophy in the pediatric population. And like I said earlier, that's going to be our focus. So, Duchenne's muscular dystrophy is a sex-linked recessive disorder that is typically diagnosed in early childhood, with several signs and symptoms that lead to the diagnosis. The disorder is frequently seen in male children with rapid progression that affects many body systems throughout the life. Death typically occurs in these patients in the third generation of life due to the development of cardiomyopathy and respiratory failure, but these patients do live with quite significant comorbidities before death. Currently, there's no cure for DMD, but corticosteroid therapy can slow the progression of the disease. But this doesn't come without consequences. As we learned in the program in the past year, the long-term use of corticosteroids comes with many detrimental negative effects. These effects include increased risk for infection, increased time for wound healing, development of diabetes and heart disease, osteoporosis, development of gastric ulcers, and gastrointestinal bleeding that all have anesthetic implications. Patients with Duchenne's muscular dystrophy will be on high-dose corticosteroids starting from their diagnosis until the end of life, so all of these side effects will likely be seen. Some other facts: it was discovered in 1861. Usually presents and diagnosed in the children aged 3 to 5. It affects about 1 in 3,500 live births and male births. Females are typically not affected by the disorder. Um, and like I said, there's no cure for Duchenne's muscular dystrophy. So the pathophysiology of Duchenne's muscular dystrophy. The pathophysiology involves the infiltration of fibrous and fatty tissue into the muscle and the progressive degeneration of muscle fibers, and this is what leads to the weakness, the skeletal muscle weakness that you see in these children. The disorder affects all types of muscles, including skeletal, cardiac, and smooth muscle, which is what leads to a lot of our um, significant comorbidities that you see with this disease. The abnormal gene for DMD is located on the X chromosome and affects the protein dystrophin. Typically, dystrophin stabilizes the sarcolemma during muscle contraction, but in DMD, the patient has a deficiency of the protein or a lack altogether. And this gene leads to altered stability of the muscle fibers and ultimately leads to a progressive weakening of all muscle types. In the early stages, it results in increased permeability of the sarcolemma, and you'll see an increase in the enzyme creatine kinase. So the obvious signs of muscular dystrophy is weakness that's more severe in the lower extremities, but as the disease progresses, so do the signs and symptoms. The disease is often diagnosed in children after a number of signs are exhibited by the child, including clumsiness, waddling gait, difficulty climbing stairs, difficulty jumping, and frequent falls. And these are extremely important signs to remember when performing a preoperative assessment in the younger pediatric population. So if the pediatric patient comes in and we're doing a surgery on a 2, 3, 4, 5-year-old patient, you're going to want to ask preoperative questions that are relative to the things that I just mentioned to help aid in the diagnosis of Duchenne's muscular dystrophy, because a lot of times the parents don't recognize these signs and symptoms themselves. Um, and sometimes as anesthesia providers, we're the ones who actually recognize that they have this condition. A definitive and abnormal sign of childhood development is the Gower sign. And I know we learned this in patho last semester in our class. But this is when children around the ages of 3 to 5 will use their hands and climb up their legs to rise from the floor. So the child won't be able to get out of a sitting position unless they use all their limbs to kind of help them get up. And because of the skeletal muscle weakness associated with Duchenne's muscular dystrophy, these pediatric patients often have a hard time lifting their head when in the supine position. And most of these patients are in a wheelchair by 11 to 13 years old and display significant signs of muscle wasting. This is extremely important when discussing anesthetic considerations of the disease. Many times the anesthetist, as we know, will use head lifting as one of the criteria to determine if they're adequately reversed from a neuromuscular blocking agent. In this population, it's not a reliable sign. We also know that patients with prolonged immobility are at risk for hyperkalemia when given succinylcholine due to upregulation of nicotinic acetylcholine receptors. So that's pretty important as well. The progressive weakness leads to respiratory weakness and restrictive ventilatory impairment. And as the disease progresses, patients become extremely susceptible to the effects of respiratory depressant medications, which a lot of our anesthetics are. This will present as a weak, ineffective cough, with patients more prone to respiratory infections, difficulty swallowing, inability to mobilize secretions, so they're at risk for aspiration. So after speaking about these signs and mentioning them, as anesthetists, we should be extremely concerned of how we can effectively manage our patient's respiratory status postoperatively, and that's probably going to be one of our biggest concerns when taking care of these patients. The patient will also have intestinal hypomotility, which will just contribute to the risk for aspiration and delayed gastric emptying. So some more clinical manifestations. Myocardial involvement is typically seen in the later stages of the disorder, but it still exists early on. It is difficult to correlate early cardiac symptoms with Duchenne's muscular dystrophy, but patients will definitely be more prone to the myocardial depressant effects of anesthesia. I think it's important to understand that patients are prone to decreased contractility and inadequate function of the left ventricle. The anesthetist should alter their fluid plan and anesthetic management according to these findings. So, preclinical cardiac involvement occurs in 62% of boys between 6 and 10 years old. That's pretty significant. And cardiomyopathy is present in nearly all patients greater than 18 years old. Some of the EKG changes you see: sinus tach, tall R waves in V1, deep Q waves in the left precordial leads. And as the disease progresses, you'll see mitral regurg, ventricular dysrhythmias, dilated cardiomyopathy. So this is just a chart that kind of shows the cardiovascular symptoms and how they progress. So preclinical, like I said, these are subclinical signs that you're not going to see, even though they're present. Can have some EKG abnormalities, cardiomyocyte hypertrophy, initial diastolic dysfunction, but they're probably not going to cause significant effects where we will see them outside of the perioperative area. And then you have the clinical stage of the disease, which is about 10 to 20-year-old, where you'll start to see these effects become more prominent. And then we have the greater than 20 years old detectable cardiac involvement, where we see significant systolic dysfunction, dilated cardiomyopathy, and arrhythmic complications. And a lot of times these patients should and will be worked up by a cardiologist before undergoing anesthesia. It's almost essential at this point, especially in the later stages of disease. So some of the anesthetic implications, and I think this slide is extremely important. And one of the things I found when I was doing research, when Alex and I were looking up Duchenne's muscular dystrophy, is I went on the website of myotonic dystrophies, and they actually have a tab that says anesthetic implications, and there's two documents under that tab. There's a 9-page document that the anesthesia provider can read, people like ourselves, before administering anesthesia to the patients with myotonic dystrophy, and it gives some guidelines and some practical advice of things to watch out for. And then there's also a 1-page document that the patients with muscular dystrophy can give to their anesthesia provider to make them aware of some of the challenges that they may encounter um, during the anesthetic or during the perioperative phase or even postoperatively. That kind of told me two things. It told me that anesthesia providers are probably pretty uninformed on how to provide anesthesia for a patient with myotonic dystrophy. Um, and it told me that this disease comes with significant anesthetic implications. So just for a few, in this slide, we're going to discuss the most important implications related to the disease and how it affects our anesthetic. The most important thing to do with a patient with Duchenne muscular dystrophy is an extensive preoperative evaluation with appropriate clinical consultations to properly identify the best treatment options to optimize their operative experience in the safest way possible. And like I stated in the previous slide, these patients will typically have a cardiologist following them before they undergo surgery just because the cardiovascular involvement is significant. Some of the respiratory implications are significant and require an understanding of the medication's effects on respiratory function. This patient population has a high sensitivity to opioid sedatives and general anesthetics, so caution must be used when dosing them appropriately. And we know that both of those medications have depressant effects. Ultimately, respiratory function is determined by the patient's forced vital capacity. Less than 50% indicates moderate disease and impaired respiratory function, while less than 30% indicates high likelihood of respiratory complications, whether it's perioperative or postoperatively. Duchenne muscular dystrophy is a restricted disease process with progression and scoliosis, so the decreased strength and ability to inhale and receive adequate tidal volumes is always a concern, especially postoperatively after we extubate these patients and they still have some of these opioids or anesthetics on board that are depressing their ability to adequately ventilate themselves. In this regard, it's a good practice to extubate these patients to non-invasive positive pressure ventilation if pulmonary function is impaired, which most likely it's probably going to be. Some of the cardiac issues generally occur later in life when the patient's 20 or 30 years old. Like I said, that doesn't mean that they can't have significant implications in the perioperative period when they're younger, but it typically occurs later on in life. It's good to know that they could develop cardiomyopathy with a sensitivity to myocardial depressant effects of general anesthetics, and they do not tolerate the stress well due to hypertrophy and have the potential for heart failure in the later stages of DMD. So keep an eye on your fluids is helpful, as well as possible use of inotropes to maintain cardiac output. And we all know that ketamine is a cardiac stimulant, so we can use ketamine as a balanced approach. Other than the big two systems I just discussed, respiratory and cardiac, you should be aware of the possibilities of weak laryngeal reflexes, delayed gastric emptying, and the prolongation of neuromuscular blocking agents up to 6 times the normal duration. And we should just plan for these issues to keep the patient safe. So creating an anesthetic plan for the patient with Duchenne muscular dystrophy. So when we talk about your anesthetic plan for this population, we're going to want to avoid succinylcholine entirely and minimize our use of the NMB agents in dose and frequency. Like we just discussed in the previous slide, they're a lot more sensitive to neuromuscular blocking agents. If you treat them as high risk in every category, you probably be all right since they're sensitive to your other anesthetics as well, and they're high aspiration risk. Also, these patients have weak skeletal and smooth muscle with increased risk of nerve damage. So you'll need to take care to ensure your airway is maintained and safe as well. More specifically, we would try to use regional or neuroaxial techniques when possible. and pre-medicate to decrease the risk associated with aspiration and minimize fluid intake due to potential for heart failure. We could use dexmedetomidine for sedation because it's not a respiratory depressant, like a lot of our other anesthetics, in conjunction with short-acting opioids like remifentanil if they are needed to limit the exposure to volatile anesthetics. And finally, we would be aware of the fact that cardiac arrest could be from hyperkalemia, and identifying that early recognition could save the patient's life. So succinylcholine is contraindicated in these patients because of altered sarcolemma can lead to rhabdo and myoglobin efflux, and they call this non-MH rhabdomyolysis that's seen in these patients with SUCs. So it's not actually an MH episode, it's just rhabdomyolysis that's caused from succinylcholine. So other things we could do is just make sure that we look for alternative signs of return muscle strength, and just be aware that these patients post-operatively after they're extubated will have a high risk for aspiration and weak laryngeal muscles. So malignant hyperthermia and DMD, just like I stated, there is currently no evidence to prove that Duchenne's muscular dystrophy is linked to malignant hyperthermia. However, the development of life-threatening rhabdomyolysis upon exposure to succinylcholine and volatile anesthetics have been seen in muscular dystrophy patients. While doing research, this is something that wasn't really consistent throughout the journal articles that I read. Some of them stated that volatile anesthetics do cause non-MH associated rhabdomyolysis, and some of them stated that it's perfectly okay to give volatile anesthetics to these patients. When I looked on the myotonic dystrophy website, and when they talked about an anesthetic plan for the patient with Duchenne's muscular dystrophy, they stated that succinylcholine should be avoided, but volatile anesthetics are appropriate and okay to use, and does not cause any, or does not increase the risk of rhabdomyolysis in these patients. So when developing a plan, you could probably use volatile anesthetics, but if anything were to happen, it's probably not going to hold up in court, and you'll most likely be liable. So we'll probably want to use Ativa and avoid volatile anesthetics and succinylcholine. So this MH-like syndrome that I talked about typically presents with signs of hypermetabolism, including respiratory acidosis, metabolic acidosis, and excessive heat production. The development of hyperkalemia after succinylcholine administration is well documented and should be avoided in any diagnosed or at-risk populations. That would include pediatric male patients due to genetically transmitted nature of DMD. So on to our case study. So the case study that we're presenting is related to a 5-year-old boy coming in for an elective laparoscopic splenectomy that's secondary to hereditary spherocytosis. The patient was seen by hematology prior to the surgery and cleared to have no contraindications to proceed. His preoperative evaluation was normal. His surgery went well without any complications. He was induced by mask ventilation, intubated, and paralyzed with normal hemodynamics during the case. After 74 minutes, the patient's neuromuscular blockade was reversed with neostigmine and glycopyrrolate, and the anesthetic was weaned off. The child was awake, moving all 4 limbs, successfully extubated, and was transferred to the PACU, breathing spontaneously with a mask. He did not require oxygen, but the policy of the facility required oxygen for transport. He was not monitored since it was not required nor warranted. When coming to the PACU, he was crying for his mother and attempting to take out his NG tube when he suddenly collapsed and became apneic. On connecting the patient to the monitor, the EKG showed severe bradycardia with a heart rate less than 50 beats per minute, so PALS protocol was initiated and the child was resuscitated. They reintubated him successfully, and the ABG was obtained after about 10 minutes of CPR. The ABG revealed a metabolic acidosis with a bicarb of 7.6. A pH of 7.06, and the PCO2 was 18.4, and the PO2 was 429. and a bicarb of 7. It was significant that the potassium level was 9.2. They gave multiple doses of insulin, glucose, calcium carbonate, sodium bicarbonate. The potassium concentration was reduced to 7 after 45 minutes of CPR, and the patient regained a spontaneous rhythm. Over the next few hours, his laboratory values normalized as well. His CK was measured on the preoperative blood sample, and he was at 15,000. But after the cardiac arrest, his CK jumped to 128,789, and his urine was positive for myoglobin. After they saw these results, they performed a muscle biopsy that confirmed DMD by microscopic and genetic evaluation. After the diagnosis was confirmed, the healthcare team had additional discussions with the family that revealed no history of muscle weakness or demonstration of Gower sign, which is kind of not typically seen in children with muscular dystrophy. You'll typically have patients with the Gower sign. An EEG on the 7th day postoperatively, the child was diagnosed with brain death and life support was removed after a discussion with the family. The autopsy results were consistent with DMD and immediate cause of cardiac arrest secondary to rhabdomyolysis and hyperkalemia. When reviewing this case, it's apparent that the only thing that could have saved the child's life would have been ABGs much earlier in the resuscitation effort to identify the hyperkalemic state. Volatile anesthetics are considered to be safe with diagnosed DMD patients, but in this particular case, it actually caused this in this patient. Or it could have been the stress of the surgery. You must look out for rhabdomyolysis, though, since that's a possibility. The important thing to take away from this is the fact that even when you attempt to avoid all triggers for undiagnosed DMD in pediatric males, you may still have issues in rhabdomyolysis with elevated potassium, and it should be considered if the patient were to go into cardiac arrest. So these are our references, and like I said, you can go on the myotonic dystrophy website and look up some of the guidelines, the anesthetic guidelines when treating a patient with myotonic dystrophy.